trifascicular block, most of the people do not want to take drugs. And intermittent worsening of the heart failure, you need to stop medications and you may require ionotropes. So you need to have a solution to which a patient can adhere to with less of side effects, and that's what CRT is all about. The basis is electrical or electromechanical dyssynchrony. It's not only electrical, but it can be electromechanical dyssynchrony. So even if the QRS is narrow, there can be mechanical dyssynchrony within the heart itself, and delayed activation of the posterior and lateral areas. And by placing a lead in the lateralmost areas, we can actually synchronize these parts. So this is again a cartoon showing that you have placed the CRT, a lead goes into the atrium, one in the right ventricle and one over the epicardial surface from the coronary sinus over the left ventricle. So what it does is gives a stimuli immediately with the right ventricle and the left ventricle simultaneously. With that simultaneous stimulation, what is going to happen is the cardiac contraction from the septum as well as the lateral wall is to occur simultaneously. So when you compare this and this, you can see the lateral wall is contracting along with the septum and the septum is not paradoxical. So what it does is improves the contraction as a whole, it improves the efficacy as a whole, and intraventricular synchrony is promoted, in which there is an increase in the ejection fraction, increased cardiac output and therefore decreased end systolic volumes, increased atrioventricular synchrony with decrease in the LA pressure, increase in the diastolic filling, and increased interventricular synchrony with an increase in the RV stroke. So increase in the RV stroke amounts to increase in the LV output. So it's something like giving skates to the heart. It will be more easily going with the same amount of work done. So cardiac resynchronization just gives you a better perspective. Here you can see in reconstruction of gated images that this is a dyssynchrony, and dyssynchrony with CRT is switched off and this is with CRT on. So it gives a very good contraction. So based on this, don't we think that any patient who has dyssynchrony will benefit from giving a CRT, be it either functional class 1, 2, 3 or 4? So what data suggested initially was all these trials occurred in functional class 3 and 4 with QRS duration which was more than 120 milliseconds, was mostly in sinus rhythm with or without ICD. So based on all these trials which showed benefit in presence of CRT, the meta-analysis showed that a CRT in functional class 3 and 4 had a 20% relative reduction in all-cause mortality, be it due to heart failure or due to arrhythmia also. But it was largely driven by a decrease in the heart failure mortality. Also, 35% decrease in the hospitalization once the CRT was in. So, this led to improvement because of improvement in the functional class capacity, decreased mitral regurgitation and ejection fraction. It was sustained for more than 1 year after putting in a CRT. It added on to the medical therapy also. So it was not that medical therapy was stopped in this. Even with medical therapy which improved the functional class, the CRT improved. The LV remodeling also took place. There were decreased in the volumes when the CRT was on. If you see here, there is a decreased diastole and the diastolic filling period increases, while the MR that was there before CRT, resynchronization is off, decreases when the resynchronization is on. So the benefits of CRT are definitely there, and based on this, the ACC/AHA gave the guidelines. The guidelines were class 1, ejection fraction less than 35%, less than or equal to 35%. A QRS duration which is more than or equal to 120 milliseconds. The patient is functional class 3 or functional class 4 though ambulated, in sinus rhythm, and is receiving optimal medical therapy. So this was the basis of giving the guidelines based on all the previous trials. Now, if the patient has no sinus rhythm and atrial fibrillation with a QRS duration of 120, still the patient benefits from a CRT. And suppose if the patient has LV dysfunction, is functional class 3 and requires a pacemaker due to either complete heart block or sick sinus syndrome, you can give a CRT directly to these patients. At this instant, asymptomatic patients, that means functional class 1 patients without any indications for pacing, that means the patient doesn't have a indication like a heart block or sick sinus with LV dysfunction, ejection fraction 35% or less, are not recommended CRT. So don't you see a discrepancy in the physiology of having LV dysfunction, LBBB and dyssynchrony in relation to the symptoms? Why should we stop patients with functional class 1 and 2 having a CRT when it benefits into their overall cardiac output, as we have seen before? So once this was done, now people started looking, what further can we do? In what further cases can we see that will it benefit or not? And the first and foremost came to the mind, why not in less symptomatic patients or asymptomatic patients who have LV dysfunction, QRS duration, if it is less than 120, why not? If they have dyssynchrony, why not an ejection fraction more than 35%? Why is the cutoff of 35% kept? Why not 40%? Why not 50%? And for the other two. So the major topic emphasis would be, why not in functional class 1 and 2? So what is the data that suggests that there might be benefit? If you see the CARE HF study, the initial inclusion criteria were 3 and 4, functional class 3 and 4. But when it was analyzed later on, there were some subgroup of patients who said, according to their symptoms, they might be functional class 2 only, and retrospectively when they were analyzed, they felt still better on a CRT on. So what happened is, there was an initial trial that came in 2006. They said that, okay, we'll analyze functional class 2 patients who receive CRT, and they took 50 patients of functional class 3 and 4 and 50 of functional class 2. And then they put the CRT and they found that both the subgroups benefit equally in terms of improvement of the heart failure symptoms, improvement in the ejection fraction and LV reverse remodeling. So it improved because the basis of therapy is not the functional class, the basis of the therapy is the dyssynchrony, and so that should help. So there were two large trials that came later on, and that was a reverse trial that was published in JACC 2008, which kept the patients, nearly 419 patients, CRT on and then later off. So patients who were CRT on with functional class 1 and 2, so there are now asymptomatic patients with QRS duration which is more than 120 and ejection fraction less than 40%. This led to an improvement in their functional class in combination with medical therapy, and also the patients with symptoms previously that was there decreased to a great extent. Also the structure of the ventricle from a spherical one came down to a more bullet shape. But the last trial that came was the MADIT CRT. Now this was a large trial enrolling 1,820 patients. Ejection fraction less than 30%. Always the basis would be QRS is more than 120 or 130 milliseconds with New York Functional Heart Classification 1 and 2. So they were randomly assigned, and what was found amazingly was a decrease in the heart failure episodes or symptoms that occurred on follow-up. That was a 41% reduction in heart failure events, and especially in those which a QRS duration was more than 150 milliseconds. So CRT combined with ICD decreased, and if you see this cardiac resynchronization therapy for prevention of heart failure, So now people are talking to prevent heart failure by giving a CRT in patients who have a QRS duration of more than 150 milliseconds. So now this mandate did say that death may not be decreased to a great extent, but it's the heart failure that is significantly decreased. The problems that we face: do patients who are asymptomatic come to you? Very rarely. And if you say that you need a treatment which will cost you a huge amount of money, they say, I'm not symptomatic, I don't want to get it done. So these are the two major problems that we face in advising such patients for CRT. Difficult to get and treat patients, and difficult to make them understand that you need a CRT when you are still asymptomatic. Just a shoot off, can we use it in a less than 120 degrees, 120 milliseconds QRS duration? Yes, there have been trials by these three groups showing that QRS duration less than 120 milliseconds do benefit, but then NEJM published a study which showed no benefit at all in QRS duration of less than 120 milliseconds. But there are group of patients who have mechanical dyssynchrony even when the QRS duration is less than 120 milliseconds who may benefit, and these can be advised sometimes that you may benefit for. So the wider the QRS, it's always better. It doesn't mean that narrower the QRS, it's worse. So wider the QRS, the better the effect of CRT is there. Whether you can give in RBBB or IVCD, not in LBBB, yes, there is a benefit based on the three trials that RBBB and IVCD, that is intraventricular conduction defects with the QRS duration which is more than 130 milliseconds do benefit, but the degree of benefit is less as compared to LBBB. The million-dollar question, why 35% ejection fraction? Why not more? So people have now started looking in that ejection fraction when it starts falling, that is maybe less than 50%, you may benefit even when the ejection fraction is more than 35% and not necessarily can be given. So it is just an extrapolation of things that are going to happen over a period of years. From functional class 3 and 4, we are now going to functional class 1 and 2, and it's not very late as of now to start thinking of advising these patients, okay, once the guidelines change, you can suddenly have an ICD and CRT, that is a combo device in asymptomatic patients. So finally, as we see the time goes on and these devices become more user friendly, they are more widespread, the cost comes down, these indications are going to evolve. The patients, all patients with LV dysfunction might be advised who have a QRS duration of more than 120 milliseconds for a combination of ICD plus a CRT, that is a combo device. And even if QRS is less than 120 milliseconds, you might advise such patients if they have mechanical dyssynchrony. So then finally overall the gist would be that all patients can be advised a CRT if they have heart failure symptoms and their ejection fraction comes below 35%. So this is going to evolve, and as the time passes on, the ACC, AHA and other guidelines are going to change based on this MADIT CRT as well as the reverse trial. So I think this should be giving an overview of how the CRT works and when we can implant.